Good morning. My name is Alex Noblo. I'm one of the faculty physicians at David Grant Medical Center's Family Medicine Residency at Travis Air Force Base, and I'm excited to discuss with you the results of my project studying military family physician attitudes toward discussing running gait retraining with their patients. I have nothing to disclose, so let's dive right in. Running-related injury remains a bane to all runners. Some good news: multiple studies like those listed here have begun to demonstrate improvements in pain and reduction in running-related injuries with gait retraining. Now, we as family physicians are likely to evaluate and treat a lot of these injuries, yet despite the emerging evidence for gait retraining, most previous gait retraining studies are difficult to translate to the clinical practice of a family physician. Many of these studies involved specialized equipment like treadmills, cameras, force plates, and other sensors to analyze and help modify gait. They also always involve multiple in-office sessions. This is impractical to implement in a busy primary care clinic, where next available appointments are always in short supply. As such, it is unclear how gait retraining is currently being utilized by family physicians. Specifically to date, no studies have been published analyzing how often family physicians are engaging their patients in gait retraining discussions, what barriers exist to these discussions, and how confident they feel in discussing the topic. With this in mind, this study sought to close this knowledge gap by surveying military family physicians and residents. Now let's talk briefly about how this was done. Likert type scale and best answer responses were collected via a cross-sectional survey of military family medicine physicians and residents. It was distributed as part of the 2019 USAFP Omnibus Survey. My outcomes of interest included the frequency with which family physicians discuss running gait retraining with their injured patients, as well as their confidence in discussing this topic and the value they place on it. Additionally, the study sought to identify barriers to these discussions. With that background, let's move into the survey results. A total of 387 out of 532 eligible registered attendees of the 2019 USAFP annual meeting responded to the survey, for a very healthy 72.7% response rate. Reviewing the demographics of the survey respondents were 2/3 male, with race and Hispanic origin broken down as you can see here. Representation from all branches and practice settings was observed. Looking at the value family physicians place on discussing gait retraining with their patients, 82% of respondents felt these discussions are at least somewhat valuable. Respondents with previous sports medicine fellowship experience reported significantly more value based on a higher mean Likert score. But when those with all types of additional training were excluded, the proportion of respondents identifying these discussions as at least somewhat valuable remained consistent at 80%. Moving to discussion frequency, 63% of respondents speak with few to mostly no patients on this topic. Those with additional training reported statistically higher discussion frequencies, such that, when I excluded this group, the proportion of respondents speaking to few to mostly no patients on the topic rose to 72%. Similar to frequency responses, 71% of respondents feel only slightly confident or not confident at all in engaging in these discussions. Again, those with additional training reported statistically higher confidence, such that when this group was excluded, the proportion of respondents feeling slightly confident or not confident at all rose to 81%. Similar to looking for confounders like previous training, I designed a question to also look at the impact of a physician's self-reported running frequency. Surprisingly, I found that less than half of all respondents reported they currently run regularly, which is defined as running greater than or equal to 1 time per week for at least 1 month. The only statistically significant effect of self-reported running frequency was found in provider confidence. Post-hoc analysis showed more confidence in those running regularly compared to those running only when having to, or those who have run regularly in the past year, but not in the last month. Now that we've looked at the physician attitudes and behaviors, let's turn our attention to the obstacles impacting these responses. The most frequently reported obstacles were lack of knowledge at 55% and lack of time reported by 24% of respondents. The survey sought to assess respondents' knowledge of the clinical application of running gait retraining using a multiple choice question. Only 24% of respondents correctly identified that a metatarsal stress fracture was the only listed injury that did not have biomechanical or clinical evidence supporting treatment benefit with running gait retraining. To summarize these findings, most military family physician respondents find value in discussing gait retraining with their patients. This is consistent with the emerging evidence that it plays an important role in the treatment and prevention of running-related injury. However, the frequency of these discussions and physician confidence on the topic were low. Previous participation in sports medicine fellowship and additional instruction in gait retraining were both associated with increased discussion frequency and physician confidence. While these relationships had the potential to confound the survey results, they did not dramatically affect the high physician value, low discussion frequency, and low physician confidence observed in our respondent population despite their inclusion in the analysis. Finally, consistent with lack of knowledge being identified as the most frequently reported obstacle, less than 1/4 of respondents identified the correct answer to the clinical application question. While 55% of respondents identify lack of knowledge as the largest obstacle in their efforts to discuss gait retraining with patients, the 76% of respondents who incorrectly answered the clinical application question suggest that lack of knowledge may still be an important barrier for respondents who identified other obstacles as their primary concern. While the results of this study have helped close the knowledge gap I previously mentioned, it is important to note its limitations. The cross-sectional self-reported nature of the data limits the ability to make causal inferences. Biases like social desirability had the potential to confound my results. However, I would argue it was less at play here, as you would expect reports of higher frequency and confidence, as these are more socially desirable responses. In terms of generalizability, one might assume that discussion value, frequency, and confidence would all be higher in the military family physician community, given the high burden of MSK injury in our relatively young and physically active patient population. Additionally, we all have to maintain physical fitness standards. While this study was not designed to address the effects of our unique patient population, the fact that more than half of respondents reported that they were not currently running regularly suggests our population might be closer to the general family physician community in regards to physical fitness than we might presume. Let's now look to the future as we get set to wrap things up. In light of respondents identifying lack of knowledge as their largest barrier, future studies should be targeted at interventions aimed to increase physician knowledge. The optimal environment for this teaching is ripe for investigation. Another approach aimed at lowering the hurdle of physician knowledge would be in the development of more simplified running gait retraining instructions. Such an intervention would also address the lack of time barrier identified in this study, as the development of non-time-intensive recommendations would assist family physicians in more practically incorporating gait retraining counseling into their busy clinic schedules. Interventions that don't involve specialized equipment or multiple visits to accomplish. It is this final opportunity that has captured my interest and where I hope to investigate further. I'd like to say some quick thank yous to Dr. Robert O. for his mentorship in refining the survey questions, and Dr. Jennifer Thornton, our biostatistician here at Travis Air Force Base. I'd also like to thank MIP Kern and their Fall 2019 writing round participants, as well as my better half, Dr. Glennis Noblo, for help in manuscript editing. And so with that, I'd be happy to entertain any questions. For those listening in, feel free to email me at the address listed here. References for this presentation are also available on request. Thank you for listening.